Thank you very much, everyone, for joining. I'll give a quick introduction and a bit of background about myself for those who don't know me, give a bit of background about what we do at OLIS. But really, what we're here to do is focus more on mapping clinical AI and mapping the ecosystem and the evolving nature of these technologies and what impact that they're going to have on healthcare, essentially. So very quickly, as a bit of background, so I'm Declan. I'm a medical doctor by background. I worked clinically as a doctor for about 5 years. And I also have a background as a software engineer as well, and that really led me down into this world. Essentially, one of the reasons why myself and the team started OLIS was because we couldn't find the internal knowledge that we needed in our own health system. So, we have a patient in front of us. How exactly should we manage this patient? They're having a serious heart attack. They have a severe infection that needs a specific regimen of antibiotics. What do we do in this health system? We were able to access, to some extent, external knowledge reasonably easily, but the internal knowledge was usually locked away. It was on SharePoint, outdated systems, etc. So we built a system using AI to index all of that, and it allows healthcare professionals to ask a question, get an answer specifically within a few seconds. And it's used now in about 500 sites across the world. And I suppose the reason why I'm going into that detail is more to illustrate over the last 4 or 5 years that we've launched this and brought it into health systems. We've learned an enormous amount about how health systems are evolving, how they're buying AI, what AI that they're actually using, and what stage of AI maturity each health system is at. There are some health systems and some healthcare organizations that are very, very early in this journey. A lot of them are, and there's some that are much more advanced in their journey as well. And we're seeing this continuous pattern emerge of how clinical AI is starting to be used. And we think we can see the direction of travel of where it's going. So that's really what the purpose of the talk is today as well. So I can kick off here and jump into the slides. And what we've noticed really is if we bring everything back to exactly what it means to deliver care, ultimately as a clinician, there are three things that you're doing, and the core of that is the patient. And the core is the patient-clinician interaction or patient-health system interaction. And essentially what you're doing is you're scanning for what this patient history is. So what has happened with this patient at this point in time, everything that exists ultimately in their chart, all their past medical history, all of their blood tests and in their scans that have previously been done, etc. And you do that idea of pre-charting and trying to get a bit of a summary. Then you see the patient and you try to take a history and an examination. You listen to what the patient is saying. But ultimately, then what you do is you take both of those pieces of information and then you try to make a decision. So you search for knowledge. And historically, over the last 50 years, clinicians will search for knowledge in their heads or ask their colleagues, and sometimes they'll reference some materials. And that's one of the points that is rapidly evolving. But all three of these points are three streams of information that collapse into one clinical decision. It's from that clinical decision that then everything downstream happens for that patient. So that's really where the center of clinical AI is then growing from. And that's what we're going to dive into here moving forward. So we call this the golden triangle of clinical AI, and we come up with multiple different names, but ultimately these three aspects form this triangle in the moment that a decision is actually made. Every single piece of software or clinical AI that has now been implemented either falls into one of these categories or supports these categories. Even AI for stroke diagnosis, etc. That helps support what's known about this patient and the investigations downstream. So they all come and converge at this point. So we've used this really to discuss how mature each of these are. The reason why this actually becomes so important is as as clinicians, if we know everything about the patient and we know everything that's happening at that visit, then we're able to query the world's medical knowledge. We're able to theoretically make the best decision possible for that patient. The key here is now that's the rapidly changed because all of those things can now be done by AI. And this actually is forming the foundation of what a potential autonomous health system might actually look like. And that's what we're going to dive into here, each of those and how AI is taking over each of these corners and how it will enable us to deliver faster care, more efficient care, safer care, and it'll also help decrease the cost of care as well, which is really, really important as technology should be deflationary in nature when it comes to healthcare. And unfortunately, it's gone the other way over the last number of decades as well. So how mature are each of these stages? The conversation stage, ultimately, this is the ambient listeners, and this is the voice technology. So something listening in the room or listening at the side of the patient's bed or in resus or, at the roadside if it's an ambulance service. Taking that patient history and using AI to consolidate it and then frame it in a patient note and logging it in the electronic record. We're quite mature along this journey, and I'll dive into that. The next corner then is the summarization of the chart. Again, that is very much down to the electronic health record, the electronic patient record, who are now adding lots of features and functionality. The last corner then of the triangle is this idea of knowledge. One is external knowledge and the other is internal knowledge. And I'll dive into each of them and why they're different and why each of them are just as important. So the conversation synthesis, what's been said in the room, ambient listeners ultimately, or ambient scribes, or ambient voice technology is what this corner really is. These technologies are ubiquitous now. They are very widespread. There are over 600 organizations running Microsoft Dex or Epic's ambient listener within their system just across the US alone. Generally speaking, in the ambient voice technology world, everything falls into two buckets when it comes to actual vendors or companies. Hospitals and health systems are either using their own inbuilt EHR or Microsoft, so the incumbents, or they're using a new startup, and some of these startups are multi-billion-dollar companies now at this stage. So examples are a Bridge or Nabla or Suki are probably the three major ones in the US, and there's about 200 plus health systems on newer kind of startups. The most important thing is we're seeing it's actually impacting care. It's increasing the efficiency of care. There was a study just published there a few days ago by one of the ambient listeners that it decreased clinic visits, the length of the clinic visit by 6 minutes, and that was in a primary care setting. So if you're given 15 minutes to see a patient and you're able to actually reduce that from 15 down to 9 minutes, that's a serious gain that those doctors then can use downstream to actually be more involved with the patient. The other aspect, which is important as well, is it reduces clinician burnout. And there's been a number of published trials reducing it from 60% down to less than 40. And there's going to be lots of other evidence that comes out about this. Evidence is a lagging indicator about the value of these technologies. The next one is chart synthesis, and this is maybe potentially the most boring, but because it's essentially owned by the electronic health care records, it's very, very difficult for new and very innovative technologies to come in and really disrupt this market. But Epic, Oracle, and then any of the ambient listeners across other healthcare settings like EMS, for example, are now starting to build these chart summarization features. This allows you to be able to, within a minute or two, see exactly what's happened to that patient in their entire history, and it summarizes that perfectly. Then we have onto the knowledge corner. So knowledge falls into external and internal, and what I mean by that is when you're a doctor or a nurse or a pharmacist or a paramedic or a healthcare professional of any kind, you need to pull on a knowledge base. And generally, you pull on the knowledge base that you either look up or what you've remembered. If we take medicine, for example, how often does medical knowledge change and evolve from an external side of things? So the figure really is it doubles every 73 days. So it's exponentially increasing. And what that means is if you graduated medical school as a doctor in the 1950s, essentially half of what you learned would be out of date by the end of your career. Now it's got to the point where half of what you learned is out of date in 2 months' time. So that is impossible to keep up with. And it's a perfect use case for AI to be able to constantly ingest the world's medical knowledge and then surface that up to clinicians when they need it within seconds. So over 50% of US physicians are using this on a monthly basis. Over 80% are using it in total, and the vast majority are using this across the US now. There are a number of major winners in this space. Open Evidence is the most recent one over the last kind of 4 or 5 years, but you have UpToDate's AI, you have Doximity, and you have a number of others. And what they do is they take external knowledge, so that's usually articles, journal articles, national level guidelines, etc., and they index them using AI, and they deliver that to clinicians, usually in the form of some sort of answer engine. And this is extremely valuable. The issue is it's generic advice and it's not specific to how your health system actually practices. And there's countless examples of why that's so important. Even some very granular examples come down to, for example, infection control or antimicrobial stewardship. Every hospital will have different antimicrobial guidelines because of resistant patterns and because of formularies, etc. It's really important that physicians in those health systems are able to follow those accurately to deliver the care. Operationally, every single hospital is different. So every health system is the same, but also every health system is different. And how the patients are referred, do they need to go to a tertiary centre? Do we give certain antiplatelets versus other antiplatelets if it's a STEMI? And what does this treatment pathway look like? So you have all of this internal knowledge that is not captured by these external engines. So yes, if you ask, open evidence or up to date, hey, what's the treatment for this cancer? It will give you the world's best treatment, but that necessarily isn't offered in your health system, or the patient actually can't get that. And that's where internal knowledge is extremely important. And it's really that last corner of this side of the triangle. And it's also extremely difficult, but it's really important that health systems start to think about how do we get this right. And what we need to think about is how do we build the brain for this health system? How do we index all of our internal policies, procedures, clinical guidelines, as well as our tacit knowledge, i.e. the knowledge that it might exist in all of the team's head, get that into some sort of system so that anyone can ask a question and get an answer within seconds, but also so that we can take that information and embed it seamlessly everywhere at the point of care. And why that's really important is it allows this triangle to start to really take shape and start to really form. So you imagine a patient comes in, you're treating them, and you're able to very quickly get what has happened to them past their entire medical history. You quickly take the history from them, and then automatically, using the AI, it just takes all of that and queries the knowledge base, both internally and externally, and then gives back, hey, in this hospital, this is the best next steps, and this is what we recommend this patient gets treated with. And that happens every single time without the physician having to search for an answer, without the physician having to do anything. And that starts to make sure that the best knowledge is surfaced for every patient every time, so that the best decision is made for every single patient every time. This is difficult to do, and health systems are early on their journey of this internal knowledge synthesis. And there's multiple different reasons for this. So one of the big reasons is that it's very messy content and it's very patchy. Not every single health system will have policies, procedures, and guidelines. They will have some, and they don't cover every clinical outcome. They're always fragmented, so they're used on SharePoint or some policy system. They're maybe on PDFs, etc., etc. So that's what's really difficult. The other difficult bit is the governance. So who owns these? What is the structure about approving each of these version controls and sign off? What is the liability associated with that? And then lastly, the other side of this problem is there's no point in having all of this knowledge if no one uses it. And this adoption is the killer here, is what I've put on the slides. Clinicians don't sit and wait for 5 minutes to log into a portal to try to get the answer to their questions. And that's why most clinical decision support systems internally to date have failed. This needs to be seamless at the point of care. It needs to be, whether it's on the phone, ask a question, get an answer within a few seconds, because that's how clinicians are expecting to get knowledge now these days. In their non-professional lives, they can open up ChatGPT or Google's Gemini and ask a question and get an answer within seconds. That's now available for both their professional career as well as their non-professional career. So it's really key that we get and understand how all this content is captured, but also then how it's adopted by clinicians at the point of care. Most importantly, though, it's the most defensible aspect of all of these three, because it's what makes your health system work. It's the knowledge, and it's one of the best assets that any health system has of how we do things here, how we treat things here. And now, with regards to a lot of staff changeover, a lot of clinician burnout, there's one study showing that in emergency medicine alone, the turnover of staff is around 40%, i.e. 40% of staff are non-permanent staff, so they're locum-based staff. So they will come in, work for a few months and then leave. So you're getting this knowledge and brain drain constantly, and more staff has to be trained up. And that's a significant risk to patients, but it's also a significant risk to the efficiency that the care can deliver as well. So being able to capture all of that knowledge in one place is extremely important to be able to deliver effective and efficient care. So I've covered a lot of this in over the last number of slides, but ultimately the question then for this internal knowledge bit of the triangle is, what does it take to actually make this real? And there's a number of different things that we need to think about here. We need to be able to ingest the content rapidly and seamlessly at scale. And how we built our platform, for example, is you can just drag and drop everything. Everything gets dragged in. It doesn't matter what format it's in. If it's Word, PowerPoint, an external website, whatever it is, the engine needs to be able to ingest that. And to date, any platforms have just taken too much time to be able to bring in that content, and therefore they're not adopted. It needs to be able to have governance processes and approval of workflows. Then it needs to be delivered at the point of care. And then we need to think about, okay, in the future state, how do we integrate it properly at the point of care into the electronic patient record, into the patient care record, so that the answers get surfaced appropriately every single time. And that's when we can start to think about how do we actually make this autonomous. The patient comes in, queries your policies and guidelines, and then it can start to take actions. Okay, this patient needs these blood tests, and would you like to approve? Yes, done, click. And there'll be a human in the loop. We will get to the stage, some health systems will get to the stage within the next 10 years that approval for those things, there won't be a human in the loop. And this is a bit more of an existential discussion of where does the liability lie, et cetera, but that's where health systems are now moving towards. For example, Cedars-Sinai has integrated their Epic instance with Open Evidence's external knowledge, and this is already happening seamlessly at the point of care. The patient note is taken, queries Open Evidence's evidence base, and then gives that decision for that patient. The clinician then decides whether to use that decision or not, but we're not far away from that taking automatic actions and taking agentic actions. So the last bit here is really the idea around we should think about how what do we want good to look like in 3, 4, 5 years time, not just I've got a big problem right now, I need to solve this right now, and then just kind of buy this. Because what results in that is you will have multiple different solutions that nothing talks to each other, and then in 3 or 4 years time we're still in a system where healthcare doesn't deliver the promise that that's supposed to deliver. So I suppose it's really a call to take a step back and look at these technologies and think, what is possible here, and if we design out this properly, what can we actually do for patients, and how can we actually deliver more effective streamlined care. So that's a very quick overview, really just end to end, of how this is starting to shape out. This is an introduction to this as a concept, and as an introductory webinar. We'll be doing a number of webinars along this theme, and what we will be doing is mapping out this triangle further around each of the points of all of the opportunity, all of the vendors that are in the space, and how they interact, and how this actually is going to evolve over time. As well as that, we dive into the evidence that's associated with each of these. As I said, it takes these things to become into practice so that evidence can then be generated, i.e. evidence itself is a lagging indicator. So we have to have some sort of forward-looking mindset when we're thinking about how to design this before the evidence actually comes in. But we have to do it in a way that's clinically safe for patients as well. So it's constantly getting that balance. So that's really what we'll be embarking on with these number of different webinars. So thank you very much for listening.